Welcome to the 5th episode of our iSense Q&A series. I am Erin Manning, the Communications Manager for the UCL-led iSense project, which is an EPSRC-funded interdisciplinary research collaboration. Our researchers are working to develop tools and technologies to track, test, and treat infectious diseases. This Q&A series is a chance to speak to and learn from experts working in fields related to infectious disease, surveillance, testing, treatment, and beyond. Today we're speaking to Dr Richard Pebody from the World Health Organization, Dr Daniela Paolotti from the ISI Foundation, and Professor John Brownstein from Harvard Medical School on the topic Traditional and Digital Epidemiological Surveillance and Their Place in a Pandemic.
Of course, thanks very much. It's great to be here. So, my name's Richard Pebody. I'm currently with the World Health Organization based in Copenhagen. So it's the WHO European Region office. And I've been there I started here in November 2019. So the timing, you could say, was a little uncanny. So I've been involved in there, sort of leading the surveillance work as the high threat pathogen lead for the team there.
Amazing, thank you, Richard. And John, would you like to go next?
Sure. Hi, everyone. My name is John Brownstein. I am a professor at Harvard Medical School. I'm the Chief Innovation Officer at Boston Children's Hospital, where I run a team that is focused on digital health and a research group in computational epidemiology. We've been building platforms for disease surveillance for over a decade, focused on novel data streams. We run a platform called Health Map and several other tools to help sort of get deep insights into emerging infectious diseases and populations and help track those infections as they spread. So it's great to be here.
Thanks for joining us, John and Daniela.
Hello, everybody. Thank you so much for the possibility of being here. I'm really honored to be in such a great company. My name is Daniela Paolotti. I'm a senior research scientist at ISI Foundation, a private research institution in the northwest of Italy. I'm part of a group called Data Science for Social Impact, and in my team, we have been working in the past decade to use non-traditional data sources to study many health-related issues, including infectious diseases. And I've been coordinating in a network for participatory digital surveillance called InfluenzaNet for the past 10 years.
Thank you very much, Daniela, and thank you for all of you for joining us today. So we'll get into questions. My first question is, can you explain to us what traditional surveillance looks like? For example, for a normal flu season before the pandemic. Maybe Richard, you could start.
Yep, no, certainly happy to do that. So, traditional surveillance, I think we can frame as what's sort of is there already in place, and clearly we've got long and well-established systems in place for influenza, which are there really to, in main terms, monitor the activity of flu to find out when the flu season starts, to understand the intensity of the flu season, who are mainly being infected, and then also importantly to understand what are the main circulating strains and how well those are matched to that season's flu vaccine, and then also help to sort of inform the composition of the vaccine the following season. And then to do that, countries have got essentially a few different components, all to try and give insights into different levels of the disease pyramid. So, starting at the bottom, or start at the top in terms of looking at the impact in terms of mortality. Many countries have established excess mortality monitoring systems to try and understand the mortality impact of flu. Then below that, we've got sort of the hospital level surveillance. So countries have established sentinel hospital surveillance systems to again look at what's the hospital burden due to flu, and that can be linked as well to monitoring effectiveness of vaccine programs in preventing severe disease. Below that, we then have the systems in primary care, so set up to monitor the level of activity in terms of primary care consultations. And again, very useful to understand the circulating viruses and how well the vaccine is working in preventing GP consultations. And then the final bit of the jigsaw is really what's going on in the community. And there are systems there, of course, the system which Daniela and team are running in terms of influenza net and understanding the levels of activity out there in the community. And then there are sort of ad hoc systems like epidemiology surveys and so on that are done, but that's, I think, a bit more sort of research focused. And clearly those platforms, when we think about pandemic preparedness, can all potentially play a really important role to be repurposed, adapted, scaled up to really help different elements of the pandemic response. But on their own, they're probably not enough, as we've seen, and we'll discuss in a little while. But that's, I think, what we'd call traditional surveillance.
Thank you very much for that explanation, Richard. Daniela, do you have anything you'd like to add to that?
Well, I think the great explanation by Richard was already very comprehensive. I just would like to add that, especially inside countries, these various systems sometimes are a bit fragmented, and the communication, especially in terms of data exchange, might result in delays and difficulties. And this is something that is happening in many European countries, as well as in the rest of the world. So this is one thing that we like to add.
Yeah, thank you. And John, from a perspective in America, is there anything else you'd like to add?
Yeah, I mean, I think clearly, as Richard said, all these different data streams all play critical roles. And I think in many ways they provide especially important insights in sort of very hard healthcare outcomes, mortality, hospitalizations. We need that data to have full concrete impact on our health systems. What they often don't fully do is provide sort of the deep sort of impact at the community level. And that's obviously where emerging infectious diseases spread. You may not see them in healthcare settings, or hospitalizations, clearly deaths follow. And so where these data sets provide sort of very important information, especially in the later parts of an epidemic as it's emerging, they're not as nimble or comprehensive to fully sort of provide that early identification. And this is where there's sort of potential gaps and opportunities in data that, of course, we'll talk about here today.
Thank you very much. So in the COVID-19 pandemic, we've of course seen a rise in digital innovations, developed at a speed we've never seen before. And although this progress is important, has the focus that we've put on digital technologies maybe seen some of the more traditional surveillance methods left behind, or have they been beneficial in this time? Maybe Daniela, do you want to start?
Sure. So I think that one of the important things that this pandemic has shown is really the importance of traditional surveillance data. So of course we have seen many digital innovations, as mentioned, as a way to enhance the traditional surveillance approaches, but we also have become acutely aware of how crucial and how important are the traditional surveillance information to accurately inform, for example, the awareness with respect to the situation, or effectively inform models. And in some cases, the fragmentation, incompleteness, and lack of coordination for traditional data has created many problems. And hopefully this is a lesson learned for preparedness in the upcoming years, that traditional surveillance data are still our best weapon to be prepared for the next pandemic. And most metric for tracking COVID, such as confirmed cases, hospitalizations, and deaths, suffered from reporting delays and uncertainties that we tried to complement with digital information. But it remains to really stress how crucial the traditional systems are to provide support in preparedness.
Of course. Thank you. And Richard, do you have anything you want to add?
No, I mean, Daniela's captured it pretty well there. I mean, I think from a digital innovations perspective, I suppose just to take slightly a step back as well. And I think when we think around new and emerging viruses, I mean, as John reflected, one of the challenges I think with the traditional systems is this gap of what's going on in the community, and that can often lead us to sort of misinterpret, the nature and shape of a new virus when it's emerging, because we don't have that understanding of what's going on in the wider population. And I think traditional surveillance systems can help, but they won't provide all of the answers. I think there's a really important role for these sort of special studies, should we call them, to understand the shape and the flavor of a new virus. How transmissible is it? How severe is an infection if you get it? And traditional surveillance can certainly play a really important role in answering those, but it also involves just shoe leather epidemiology of finding your first cases, having clear case definitions, following up on them, following up on the contacts, these sorts of things, to understand what's the likelihood of someone else being infected, and having clear protocols in place to do that. And I think digital technology can really help with some components of that, in terms of starting to piece that information together. And I think this pandemic has uncovered gaps in our preparedness, to be honest, in terms of the requirements that were put in place around contact tracing, for example. I mean, we never anticipated having the need for those types of systems, and most countries have had to build those systems from scratch. And that's obviously required digital innovation as well. And much of the data that's come from that has been really valuable, actually, to help inform the response and to understand how well it's going. So I think there's important learning for us all there, as there are in a number of other areas, but which we'll come to. But anyway, that my initial reflections over now.
Thank you very much, Richard. John, do you have anything more you'd like to add to that?
Yeah, I mean, listen, I think as someone who's been in this field of digital epi for a lot of years, doing this kind of work, there's some good reflections on where the data is valuable and where it maybe is less valuable. I think that, clearly in some of the tools that we've been building with WHO around early detection and the first signs of what was emerging in China, these informal, non-traditional sources provided situational awareness where you just didn't have access to any other information stream. So I think there's value there. I think there's major value in some of these symptom collection tools, whether it's tools like InfluenzaNet or symptom surveys. And these provided really critical information resources, especially in the beginning parts where we didn't understand sort of attack rates in different age groups, we didn't understand demographic factors. I think they played such an important role in sort of shaping our knowledge of the virus. I think over time, clearly some of the more routine surveillance, some of these, these tools are maybe less valuable because, you have very good case ascertainment that's happening in the community level. And especially here in the US, where you have incredible testing, some of those syndromic data sources become less critical in my view. And maybe that's controversial. Other people might disagree, but, things like mining Twitter and Google searches and other things, which we've done for many years, just I don't think are necessarily going to replace what we could collect if we have robust public health surveillance. I'll just say that I think some of the opportunities, and we've seen a lot of investment from companies like Google and Facebook and others, and surveys and other tools. The values and the nimbleness of these tools and the kinds of data they collect. So for instance, we did work in being able to collect information on mask wearing adoption in communities. That's not data that traditional public health can collect, or understanding the impact of mobility. Again, like you can shift some of these tools and surveys to collect not only health outcomes, but behaviors. And I think that, in my view, is where there's huge advantage. Yes, we can write another paper that shows that another data source can provide a 2-week, early indication of a virus. We've done that, but I think now it's time to think about the richer kind of data that you can collect from these sources. And I think that will sort of cement the sort of place of these tools more ingrained in public health. And we've seen this with our collaborations with CDC and WHO.
Yeah, of course. Thank you very much. I have a question from an audience member who says, I'm interested in encouraging more researchers to use data from Google, Bing, etc. A common objection is the failure of Google flu trends. How does the panel recommend countering that objection? Maybe John, would you like to start?
So the objection to Google flu trends. Yeah, I mean, listen, I think that there was some good reason why, Google had criticisms, received those criticisms, because there was challenges in the way that they were modeling the data. And frankly, I mean, they were definitely put out a system with a lot of sort of confidence of what the tool could do. I think we have over time tried to change the narrative to, it's not just about one single source of information, and the challenges of providing one source of truth, but it's about integration. And so we've been really thinking about sort of, it's not a single stream of information, whether it's a traditional public health data source like hospitalization or deaths, or more sort of novel one. It's how do you integrate these sources to provide that sort of that best understanding of what's happening on the ground. And as long as we take a more sort of thoughtful approach about these data sets, of course, improving the methodologies and understanding the biases and sort of the populations that capture, how these populations change what they search for and how they behave on these tools. But I think as long as we recognize that it's not a single source, then I think this field will continue to flourish.
Thank you very much, John. Daniela, do you have anything to add?
Yes, I would like to stress the word that John used, which is integration. So, of course, when people talk about digital technologies, the finger is pointed right away to the biases affecting these sources. Of course, we are well aware, for example, Google search activity is highly sensitive to news coverage. Twitter data are also can be polluted by the public discourse. But as John said, the trick is to use not only one source of data, but to use an ensemble of different data. And we don't have to forget that even data generated by public health are biased. For example, GP and general practitioner surveillance-based data are only referring to people who go visit a doctor, who report their case and their symptoms, and who have access to healthcare and so on and so forth. These are all biases that have to be taken into account. And so the way forward is to really be aware of the limitations of each data source and try to combine as many data sources as possible to have a broad picture of the situation.
Thank you very much, Daniela. Richard, do you have anything you'd like to add?
I mean, only in so much to certainly agree that none of these data sources is perfect. That's for sure. And the trick really is to recognize that and to take the sort of overview of how they all come together. Whether that's done just on a more informal level or more formally within a modeling framework. And some modeling teams do that very nicely, these sort of Bayesian frameworks, to see how they fit together and use those, for example, to estimate infection severity ratios and so on. So there's some really nice work that's been done pulling together different traditional and non-traditional data streams in that way.
Thanks very much, Richard. I guess this question leads on from what you're saying, Richard, that there are many very nice studies out there. Can you let us know some of the different sites that have been mined for surveillance during and before the pandemic, and what kind of data sources are useful for epidemiological surveillance? Maybe you want to continue, Richard?
Sure. Clearly there's a range of different, and John and Daniela will talk at length about this in terms of what's used for alert detection purposes. And those come from, a range of sort of media monitoring. There's a number of tools that are used for that. And that can really provide very good insights into early pickup of events of importance, which are going to need further kind of investigation and verification. So that's extremely valuable to give us those early signals of what's going on. And I'm sure John will probably want to talk a little bit about sort of Wuhan and so on and that perspective. But then also to touch on also, the other ways the data can be used. This isn't so much on alert detection, but in terms of just to focus in on this issue, for example, on the mobility kind of monitoring, and that's I think we've found is actually a very powerful tool to actually, once the pandemic's been up and running, to actually understand. Many countries are recommending the implementation of public health measures to try to reduce transmission, but how are they actually doing that? And use of digital technology, the use of social media like Google to try to understand whether there is actually reductions in mobility is very, very powerful, and that's been used a lot. And we found that also very useful then to sort of combine it with the epi data. So then are we seeing then things converging together, or are we seeing divergence? So for example, is there a decrease in mobility, but still an increase in the epi curve? And we've seen that in a few countries, and that's been an early signal, we think, of the emergence of these more transmissible variant strains. So those countries which don't have capacity to sequence, at least now, it can be a way of picking up those type of signals. So there are various ways of sort of using this type of technology in a smart way to give early signals.
That's really interesting. Thanks, Richard. John, do you want to follow on from that?
Yeah, I mean, I think I'm actually fully aligned with Richard on that, because his last statements, I mean, yes, we've been hyper-focused on these tools as sort of alert mechanisms, and we work closely with the WHO and their EIOS system that captures a lot of this data and provides that sort of early event-based detection of events. But I'm probably much more optimistic about some of the things that Richard just mentioned, which is how do you start connecting the sort of ancillary data, population mobility, contact networks, mask adoption, to understand the impact of different interventions. Early on in the pandemic, we published a paper showing the value of lockdowns, but that was based on the fact that we had data about mobility and understanding what the population behavior was in response to government mandates. Same with masking and other types of interventions. These are the kind of data sets that have allowed us at large population scales to understand what the population is doing and how they're reacting to mandates, that then subsequently allows us to understand the value. So again, I just think that is a huge open white space for this field to continue to push, and it doesn't conflict or duplicate really any data set that's out there. And I think that it will continue to show tremendous value going forward.
Thank you very much, John. And Daniela, do you want to add anything there?
Well, there is not so much to add to what John and Richard have already said. I just would like to shed some light on an additional aspect which I think is super important, which is the public attention and public perception. So we managed to use digital data, such as, for example, users' activity on social media like Reddit or searches on Wikipedia pages to really study the way people react to exposure from news and from media with respect to COVID. To really measure the attention, the collective attention of individuals to a pandemic. And what we found is interesting, that the attention is driven by media coverage, but declines rapidly, even though the number of cases remain high. So this is really important to study the awareness of the general population. And another thing that we did was super interesting was to study the perception of risk. And we found that at the beginning of the pandemic, the risk perceived by individuals was way lower than, of course, at the end, especially for themselves of getting infected. So we think that these digital technologies can really help study some aspects of the public reactions and awareness and perception that are very hard to capture otherwise. Going a little bit beyond disease tracking and the epidemiological aspect. So this is also very important.
Thank you very much, Daniela. I have another question from an audience member that asks, is there a risk of introducing systematic biases with using digital methods, including online surveillance? For example, with COVID-19, the case is the highest mortality is for over 75, who are also least likely to be on Twitter or Google all day. Can digital methods be modified to account for these factors? Maybe Daniela, would you like to go?
Yes, this goes back a bit to what we were saying earlier on, that each surveillance method basically has their own bias. What is important is to assess the kind of biases during non-emergency times, so to see really how different data sources can be integrated, how the biases can be corrected, and so that when emergency times come, we are ready to capture the right information, being aware of the limitations of each data source. So we are very aware that digital technologies cannot replace traditional surveillance, but they have to be used in integration with them. And we have to be aware of the biases studied and researched in non-emergency times. That's what is most important.
Thanks, Daniela. John, I'm conscious you need to leave in a couple of minutes. Is there anything you want to add?
Yeah, I'll just say this, and then I unfortunately have to drop. But yeah, that's a great question, and it's one that comes up almost every single. It's almost like the guaranteed question every time I give a lecture on this topic. It's who are we leaving behind? And I think that is super critical when it comes to COVID because of the very specific age differentiation, but also some of the disparities that exist in the communities that get hit the hardest by this pandemic may not be the ones necessarily most quick to access the same technologies that we're looking at. And I'll just say that we study this pretty significantly. I mean, we have a series of collaborations with SurveyMonkey and Facebook, and they have a deep understanding of the populations that access those tools and don't. And we use survey-based weights to make those adjustments and clearly try to account for the differences between the populations that use these tools and also, versus the populations that are getting hit the hardest. So it's a good question.
Thanks very much, John.
All right. Thank you very much.
Thank you very much for joining us. Have a good day.
You too.
Bye. Take care. Okay. Richard, do you have anything you'd like to add to that question?
I think it's all been said actually by Daniela and John. So yeah, nothing more from me.
Thank you. Okay, thank you. The next question, also from an audience member, is where should we be planning to be in 5 years' time? Should we be establishing national, international centres of digital epidemiology? What would be the advantages of such centres? Maybe, Richard, would you like to pick that one up?
Sure. My short answer is yes, we definitely should. I think, the pandemic, for obviously all the sort of negative things that it brought, it is also, in a way, it galvanizes and brings together such a sort of global body of expertise and resources, in a number of different areas, obviously in the area of digital technology, obviously in vaccines, all sorts of different areas. And I think that's created and will create a big opportunity for this area. And I think we should really grab it. I think that there would certainly be big value in setting up these type of centres because, I think having those hubs can then form a focus for, really sort of determine it, because we know infections don't know national borders. We need to sort of work out what are the key questions, what are the optimal methods to use, how can we further build on what's been done so far, and they can also act as hubs for data as well, so that where different companies and so on can potentially share their data in a safe way for kind of public health and research purposes. So I think they could be a very powerful sort of potential mechanism to have in place, and it's going to obviously need investment from the right bodies. But I would be very supportive of that type of thing.
Thank you, Richard. Daniela, do you have anything to add?
Yes, well, it must be said that during the past few years, there has been a tremendous effort from the public health institutions all over the world to really become the end user for such digital technologies. Especially with participatory surveillance, the approach has been owned really by the national institutions in the various countries in which the participatory surveillance system is deployed, so that the data collection is fully controlled by public health institutions. On the other hand, when it comes to so-called big data generated by big tech companies such as Facebook or Google, then the situation is more problematic because the data have so much value and they can really generate so much public value for research and for public health, but they are owned by private sector. They are owned by private companies who still want to, of course, make business out of this data. So in this sense, there should be a convergence between governmental actions and private interests, so that these data are not put public. Of course, because of privacy, they cannot be made publicly available at a higher resolution level, but they could be somehow given to public health institutions to be exploited in a more effective way for public health reason. And so the needs for the future is to really create more liaisons between national agencies or even global agencies and these big private sector companies who are the data owner and who should allow the public sector to exploit the value of the data.
Thank you very much. Another audience question is, do you think digital epidemiological data can be used to detect emerging zoonosis? Who would we need to engage for this? For example, vets. Richard, do you have an answer for this question?
Yeah, it's a tricky one, and I mean, I think again this comes to this issue of thinking very carefully on what we think digital technology can do vis-a-vis other sources of routine and non-routine surveillance data. I mean, I think this whole concept, obviously, of One Health and having strong animal surveillance systems in place is really important, and I think is obviously being recognised more and more. I wouldn't necessarily frame that as digital surveillance, but that very close link with the veterinary sector is really important. Obviously we recognise that in the flu world, with swine flu and avian influenza, but there's clearly a whole range of other zoonotic or potentially zoonotic infections which could jump from the animals to humans, and a lot of that will come from farmed animals or indeed from the wild. In terms of digital technology, I think probably media monitoring is probably the one area where that might play an added role in terms of coming up with alerts. But I think we need something a little bit more in terms of a signal in humans, I think, before digital technology is going to sort of provide otherwise added value. But I'm interested to hear what Daniela thinks. Yeah,
thanks, Richard. Daniela, would you like to add to that?
Well, I think that digital technologies can help in assessing, again, public attention, public awareness. For example, there was a study we did a couple of years ago on African swine fever, which is a disease that affects pigs and wild boars. It doesn't affect humans, but it can be really potentially really disruptive for economy and for meat market. But people are not really aware about the fact that this is becoming some sort of really an epidemic in many countries, especially in Europe. And so we try to use Wikipedia click rates on pages related to African swine fever to measure the public attention to this threat whenever there was an outbreak in a European country like Poland, Hungary, and so on and so forth. So these kind of technologies can be used in this case not really to track diseases, but really to measure the awareness and to measure the public attention. In this sense, I think they can be really promising.
Thanks, Daniela. We have another audience question around contact tracing, which you mentioned earlier, Richard. So do you think traditional contact tracing is still realistic or useful when the number of new daily cases exceeds a high number? For example, the UK launched contact tracing in May 2020 when new daily cases were more than 1,000. Richard, would you like to speak on that one?
Yeah, no, sure. So I think that the message here is that test and trace. So this idea of ensuring that suspect cases self-isolate and contacts are followed up and quarantined. It is at the bedrock of what needs to be done to reduce transmission levels. I mean, some of the modelling work suggests actually that the self-isolation is probably the most important thing, and for people to do that really as soon as this they have their first symptom, because we know, at least for COVID-19, that in terms of infectiousness, that's when most of the transmission is going to happen, just before the symptom onset, and that when they start. The contact tracing, I mean, it does make some contribution to reducing onward transmission, but in effect, often that happens a little bit late in reality. But nonetheless, it still is, it does contribute to reducing the R, so it shouldn't be ignored. Clearly, when case numbers are very large, it becomes logistically challenging. So a lot of it does really rely also on having good public engagement and ensuring that the public acts, when they know that they've got symptoms, that they do self-isolate. And there is a potential added role that many countries have demonstrated for the use of apps to pick up close contacts. And that can be kind of reduce the workload if countries have demonstrated, some at least anyway, that those do have potential added value when the take-up of those apps obviously is high. Clearly, if coverage is low, then the added value isn't so much. But when there's high population coverage, they can have some added value. But contact tracing can have added value. But as we've seen, these wider public health measures, they're the ones that really can have a lot of impact in terms of reducing transmission by all these physical distancing measures and reducing movement, which again can be monitored through these Google Mobile and so on.
Thanks very much, Richard. Daniela, would you like to add to that?
Yes, so of course contact tracing is the traditional form, at least, is crucial, especially at the very beginning of an epidemic and during the early stages of the pandemic. Is an effort that could have been enhanced in a much more effective way in many countries, and that was somewhat neglected on later phases of the pandemic. Special attention deserve the digital contact tracing apps that during the first wave were created in many European countries. It's worth mentioning the fact that there is a study from the group in Oxford, led by Fraser, who just published the results of quantifying the impact of these digital contact tracing, and they showed that actually the adoption of these app really made a difference in reducing the number of cases, of hospitalizations, and even of deaths across the population. So it is important to stress that these technology can really make a difference in reducing the impact of the pandemic. For example, the very big problem is the integration with the health system. In Italy, we had many issues because the app was working well, but there was no end receiver on the healthcare system that would somehow act upon, for example, a suspicious case. So these really reduced the impact that the app could have had during the first wave of the pandemic in Italy. So it is important to stress again how public health institutions should be the end user, the receiving user for these kind of technologies, and then they should act upon the results provided, the evidence provided by these technologies.
Thanks, Daniela. And you talk about linking into healthcare systems. I wanted to ask a question also about wearable technologies, which the purchase of wearable technologies has increased during the pandemic. And how is this data maybe important to surveillance? How can it be used, and how can it be added into the healthcare system? Daniela, would you like to go?
Yeah, of course, wearable sensors can really provide detailed information at an individual level in real time. And really the kind of information they can provide is super interesting and super important. There were many studies, many interesting studies, for example, about disruption of sleep, reduction of physical activity, and also in physical activity as a proxy for mental health problems. So wearables can really help shed a light on problems that would be very hard to be caught by public health. On the other hand, again, these kind of data are privately owned, and so having access to these granular level of information is basically impossible for public health institutions. And so again, we have to rely on private companies to allow the use of this kind of data. So even in this sense, even more for these kind of technologies, there should be some more cooperation between the public health sector and the owners of these data, which are really crucial to shed real-time a microscope in real time on what individuals do during, for example, a health emergency, a health crisis such as the pandemic.
My last question then is that although online data can be very useful, there are concerns around privacy and efficacy, which we've touched on a little bit. How do we ensure privacy is upheld and data is used in an ethical way? Richard, would you like to take this one?
Yeah, no, I mean, this is obviously really important, and there's a public trust issue here, and we need to make sure that the appropriate governance frameworks that countries have in place are respected, so I think that's the essence to it, and certainly for the UK and for the EU, those frameworks for sharing of potentially patient-sensitive information are there, and we need to make sure that patient identifiable data isn't put into the public domain without patient consent. These types of things. But on the other hand, there is a wealth of information that's being held by private companies, and so we also need to kind of see what potentially the public benefits of that are, so that to be shared in a non-disclosive fashion, but it needs to be with the appropriate checks and balances in place. So it's a fine balance, but I think there is an element of sort of obviously maintaining public trust in both in the private sector and of course in the public sector as well.
Yeah. Thanks, Richard. Daniela, do you have anything to add?
Yes, just one little thing about making individuals and users aware of the importance of the digital data that they somehow share on digital media. So in this sense, some empowerment, some enhanced awareness in the general public of the value of the data that they share on digital platforms should be probably at the center of this discourse. Of course, we can put in place all the regulations that have to protect the privacy and security of the data, but then people have to be aware of the importance of their own data and have to demand that their data are used for the public good. In this sense, I think participatory surveillance goes a bit in that direction, in the sense that it involves directly the general public in the disease surveillance in a way that makes them aware of the active action that they can take to inform public health institutions. On the other hand, they should be also aware of the fact that the information they share with Facebook could be used by public health institutions to generate value, and so they should demand Facebook that these sharing happens in the right way, of course, but that it is done.
Thank you very much. Well, that's all we have time for today, but I would like to thank both of you for joining us and for sharing all your knowledge and expertise. It's been really interesting to hear from both of you. Thank you very much.
Thank you.